Welcome to the webinar, You, Me, and the Computer Makes Three, How to Integrate the Computer in the Exam Room for Optimal Patient Experience, What Learners Should Know. Hi, I'm Barbara Lewis, the Managing Editor of .com, an online communication skills learning management system for hospitals, medical schools, and residency PA and NP programs. And joining me today are three experts in this field who have researched, written, and taught computer integration in the exam room, a very important topic as evidenced by the high number of webinar attendees which we have today. So welcome Meg Chisholm. Let me go on to the next slide here. Anita Rantanagosa and Lolita Alcareschi. Today we're covering three important subjects: the emergence of EHR and the effects on communication with patients, engineering the EHR integration for relationship-centered care, and teaching effective practices for integration. So please type your questions in the chat box in the panel, and if we don't have time to answer them during the webinar, we'll certainly answer them afterwards. A recording of this webinar and the PowerPoint slides will be posted on the .com website within a few days. So let's get started. Nita?
Thank you. So I don't think we need to spend much time convincing you all that the rise of the computer has affected healthcare communication. You're here because you already know this as healthcare professionals, teachers, or even patients. So I'm just going to briefly highlight some of the insights we can glean from the current research about how EHRs affect relationships in healthcare. Next slide. EHRs are not new to healthcare, with some foundational work decades ago in a variety of systems like the VA, the Brigham and Women's in Boston, and Indiana's Regan Street Institute. However, the rise of electronic health records really accelerated in the U.S. with the 2009 HITECH Act, which authorized the Center for Medicare and Medicaid Services to provide billions in incentive payments for the adoption of EHRs that met certified requirements for meaningful use. Next slide. Now, I think most of us accept that electronic health records in some form are here to stay. There's been extensive research which continues on about evaluating the impact of electronic health records and meaningful use on the quality of care. That won't be the focus for today, but studies have yielded mixed results on this impact, looking at things as specific as computer order entry for particular medications or a variety of decision support tools. But on its surface, there are many benefits of electronic health records. These include the accessibility of information across patient transitions of care, the ability to leverage the data to improve population health, and the ability for patients to access and provide input into their personal health record. So at the same time, though, there's a growing recognition of the challenges of electronic health records, and this partly relates to the direct effect of electronic health records on communication in the room, as well as on clinician and staff well-being. Next slide. Dr. Alcareschi, who will conclude today's presentation, recently published a systematic review of the literature about the effect of electronic health records on patient relationships. And in the 25 eligible studies about patient perceptions of electronic health records, most studies found no difference between pre or post or in comparison with a non-EHR time period. However, the authors highlighted certain aspects of positive deviance which we could be aware of, such as specific implementation features of how to engage patients in the technology and the importance of clinician training on how to use electronic health records in the room. And although this literature remains limited as well as with some potential biases, it's important, I think, to examine a few specific studies where researchers actually went into the exam room via observers or videotaping to look at how specific behaviors were affected by use of the electronic health record. Next slide. So one key finding is that electronic health records can actually shape and set the stage for the visit agenda. In this international study, electronic health records actually shaped the beginning of 7% of openings actively, for example, with reminders about healthcare maintenance. And then in another 10% of visits, the electronic health record passively shaped the opening, for example, a provider noting a test result or gaps in the record. And this is really important because the agenda setting portion of the visit is one of the core communication skills that allows patients to engage in the visit, to set their concerns, and it also impacts efficiency in a visit because agenda setting with patient concerns can reduce the frequency of doorknob questions. For example, hey doc, I just wanted to talk to you about this back pain I've been having and I forgot to mention it earlier. So thinking about how electronic records shape the visit agenda is an important consideration. Next slide. Other studies have also looked at the way clinicians interact with computers during the visit. And in this recent VA study, primary care providers were looking at the screen for 39% of their visits, and they were silent for a third of the time. Both the screen gaze and silence were associated with lower patient satisfaction, and silence was associated with decreased patient-centeredness in the visit as well. Next slide. And then one of the interesting before and after studies happened in 2005. This was Rich Frankel's study where he looked at how communication changed with the implementation of an electronic health record. And in this, I think there are reasons for hope and not just despair. Clinicians who showed patient-centered communication before the implementation of the EHR tended to use their new EHRs to engage and teach patients during the visit. Unfortunately, those who demonstrated less patient-centered communication tended to worsen, engaging patients even less. So this raises the importance of teaching core communication skills as part of professional training, and also raises the hope that clinicians can be trained on how to use computers in positive ways during the visit. Next slide. Finally, I just want to highlight some of the ways that EHRs affect the care in safety net systems serving vulnerable patients, which is near and dear to my heart because that's where I work. So the high-tech incentives were really key to allowing systems like my own to afford fully functional EHRs for the first time. And this can help fill in some of the gaps of care for patients with limited health literacy or limited English proficiency who may not know what's gone on in the emergency room or other settings. At the same time, these are also populations that have been shown through research to experience barriers to care and communication that make them less engaged in the visit or reduce their ability to engage in shared decision making. So there's also risk of leaving them behind in the digital divide as well. Next slide. Health IT, however, does offer some incredible tools that can allow patients who have communication barriers to bridge that gap. In this example of this video, you can see a video medical interpretation in the exam room. And so when we surveyed our patients in the waiting room about what they felt about clinician computer use, we found that patients with limited English proficiency were more likely to report that their clinicians use computers a high amount, but they also felt more positive about that use. For example, LEP patients had greater odds of feeling that the computer helped the providers remember their concerns and were less concerned about feeling like they weren't heard in the visits. However, when we recorded video encounters in these safety net visits, we also found that higher computer use was associated with observable differences in communication. For example, more patient and clinician chit-chat, more clinicians disagreeing or clarifying statements of their patients, and lower overall ratings of the quality of care offered by patients after the visit. And then in visits with limited English proficiency or limited health literacy patients, we found an increased focus on the biomedical topics. So this raises concerns about really thinking critically about how EHRs affect the care in diverse settings and serving diverse populations. Next slide, and I'm going to turn it over to my colleague.
Thank you, Nita.
Thank you. So although Dr. Al-Qureshi's systematic review suggested that the EHR hasn't had a significant impact on patient satisfaction, communication, and the clinician-patient relationship, these findings may actually reflect patients' very low expectations for their clinical care experience and not capture the real opportunities we have with the EHR to move from just okay care to clinically excellent relationship-centered care. So the few positive impacts described in that review like the ones by Kaiser, may reflect those healthcare systems' intentional strategies to take advantage of the opportunities presented by the EHR to actually improve the clinical experience for both patients and clinicians. Next slide. Relationship-centered care refers not only to patient-clinician relationships, but to relationships between or among clinicians, relationships with the community, and within the clinician him or herself. Let's take a moment to reflect on the challenges and opportunities the EHR present to clinician well-being. Next slide. I think we can all think of the many challenges of the EHR, as this study showed. It surveyed physicians across all specialties in the United States, and of the approximately 5,000 physicians who responded to the survey that used EHRs for physician order entry, the satisfaction with the amount of time spent on clerical tasks was quite low, and these docs were also at higher risk for professional burnout. Next slide. So currently, we're conducting a systematic review to identify undergraduate and graduate medical education interventions that would be effective for the prevention of burnout. This study that we're doing now is made possible by the Arnold Gold Foundation, and we're looking forward to seeing if anyone has described or is looking at ways of addressing EHR-driven burnout during medical education and training. Next slide. We may also learn lessons from the field of human factors research about how to overcome EHR-driven challenges to well-being and relationship-centered care in clinicians and patients. So human factors research has been used extensively in aviation and other high-reliability industries such as nuclear power, in which precise coordinated actions of humans and technology can make the difference between life and death. With the introduction of computers in the exam room, cockpit design has become increasingly relevant to medicine. So cockpits are designed to optimize a joint focus of attention among crew members and their instruments. Medical exam rooms, in contrast, have typically not been designed with this need for both interpersonal and technical attention in mind. So using lessons learned from the aviation industry can help medical providers integrate computers into the exam room in a way that optimizes well-being and system performance. Next slide. So to maintain a joint focus of attention, you really have to pay attention to where the clinician is seated, where the patient's seated, and where the screen is. So number one here, exclusive, is a blocked view. The computer is a physical barrier that blocks vision between physician and patient, and the physician and patient can't share looking at the screen at the same time. And as you go around from 1 to 2 to 3 to 4, you become more and more open, with a view where the computer doesn't obstruct eye contact between the physician and patient, where it would require a very small adjustment for the physician to turn towards the computer and patient, and where patients and the physicians are physically closest. Next slide. So at Hopkins, we're looking at other opportunities for interventions to improve the patient experience. Over the past several years, Hopkins, like other medical institutions, has gradually been rolling out the EPIC health record system. One of the institution's stated goals for this rollout is to improve communication with our patients and with each other via the record's patient health portal and other features. But as we've just discussed, such systems also require that providers, nurses, and other members of the care team spend a lot of time documenting patient information on the computer. Next slide. So in order to ensure that EPIC didn't change for Hopkins physicians, who is at the center of what we do, the patients, next slide, an initiative from the Center for Innovative Medicine's Miller-Colson Academy of Clinical Excellence put together a video to remind faculty and staff of the do's and don'ts of using EPIC while interacting with patients. Next slide. Based on etiquette-based medicine, EBM, fundamentals that were described by Kahn in the New England Journal article in 2008. Next slide. The video and the accompanying cards introduced the Miller-Colson's AVC guidelines for using EPIC, reminding us of certain things that we should do as we navigate the system. Importantly, we should try to involve the patient and continue to use eye contact as much as possible. Again, that joint focus of attention described for use in the cockpit.
Okay, thank you, Meg. Anything else? Meg?
That's it for me. That's it for me. Thank you. On to Dr. Al-Qureshi.
All right.
Great. Thank you, Megs. So my name is Lolita, and I'm going to be talking about some of the best practices for EHR integration, and also talk a little bit about how we can approach this with some of our trainees. So in terms of best practices, let me just see if I can advance to this next slide.
You should be able to.
I clicked.
Click on the slide.
Yeah. Great. So we've compiled a list of best practices to help providers use the EMR in a more patient-centered manner. These were based on, as Nita and Meg had mentioned, our published lit review in JGIM, as well as consultation with experts in the field, and our own collective group experience, which spans pediatrics, internal medicine, in a variety of settings, including inpatient and outpatient medicine, both in private, academic, and community health and FQHC settings. The mnemonic that we put together is entitled Human Level. The level component was actually put together by the Kaiser Permanente group in 2004. And since then, of course, with the increase of EMR use and meaningful use, we then augmented the mnemonic with the human component. And we're going to go through this just now. So the first one is honor the golden minute. So when you walk into the room, don't make a beeline for the computer. Instead, walk in, touch your patient's hand, greet them, and elicit their own concerns in their own words for what brings them in. This is important because it shows your patients that they are the most important thing in that room and that you're taking their concerns directly from them and not relying on a computer to tell you what's going on with them as a proxy. Second is use the triangle of trust. So position your lovely physician and your lovely patient, and whatever that EMR is, be it on a computer screen, perhaps you have something like a computer on wheels or a tablet, but position it such that each of you can see that computer screen so that there's this shared transparency of what's going on. Research shows that when patients know what you're looking at and how you're using the computer, that makes them not only more trusting of you and what you're using it for, but also makes them feel more confident about the quality of care that they're receiving. The utmost in mobility, of course, is something like an iPad or a tablet, but even a screen affords some flexibility. And if you're unfortunate to practice in some of the rooms that I practice in where the screen is actually bolted onto the wall, then to use the triangle of trust, you have to move what is flexible in that environment. So if that means moving your chair or the patient's chair over so that you can both see the screen together, then that's what needs to be done to establish that triangle. Next is maximize patient interaction. So as Nita had mentioned, of course there are some barriers with using the EMR in patient care, but looking beyond that, it's a real opportunity to use it to facilitate engagement and education and shared decision-making between a provider and a patient. So look for ways to engage them. Map and graph values in their labs or their vital sign trends. Pull up images so that you could review those together. And then think of the EMR not just as the EMR itself, but also as the computer and the internet, and use that as a portal to a whole host of tools that you can use to educate your patients. For example, you can research and see which free apps you might like to better educate your patients on asthma. There are great free videos on websites such as YouTube on how to use medical devices such as an EpiPen. Get familiar with different imaging resources that you might want to use. Even Google Photos is useful to try and illustrate what you want to explain to a patient as opposed to giving it to them in writing. And for patients who have impaired communicative ability, for example, this picture shows a patient with a trach, you could use it to actually literally communicate between each other. So think of the computer not just as the EMR and what resources that holds, but in terms of the computer and the internet in general. Next step is acquaint yourself with a chart before seeing the patient. This is crucially important so that you can get up to speed in terms of what labs have been done, what referrals have been done, read past visits, notes with specialists. Especially in today's practice of medicine, lots of providers may be providing care to a patient, so this helps get you up on speed before the patient is actually with you in the room, and it spends awkward minutes of silence of you searching for this while they're there in the room. Instead, you can walk in having already oriented yourself as to what's in the patient's chart, and you can proceed from there. Nix the screen if things get emotional, if things get sensitive, if an important topic comes up. As you can see in this comic, at least she's trying to look at her patient there and she's saying don't be scared. But what you really want to do is disengage from the computer. You can miss subtle cues if you're just focused on that screen and you're not attending to what's actually happening with your patient. So remove your hands from the keyboard. Don't even face your body position in the orientation of the computer. Instead, you want to disengage from the computer and the technology and give your patient your full attention so they know they're the most important thing in that room. Let your patient look on. So as you establish that triangle of trust, let them see what you're doing. Anecdotally, I've heard stories about patients wondering, well, what are they doing? What are they typing? Are they answering email? Are they on Facebook? So let your patient see that your activities are actually related to their care. Eye contact is perhaps the most important nonverbal communicative behavior providers can show their patients to let them know that they're engaged, that they're listening, and that they're there with them during the visit. So by all means, try and maintain eye contact as much as possible. If you're not a particularly good typist, I would highly recommend taking typing classes, because the ability to type while looking at a patient, or at least back and forth, is critically important to try and make that visit as smooth and as conversation-like as possible. Value the computer. So for those of you that are familiar with ZDoggMD, he puts out hilarious videos on YouTube that are fantastic on a variety of issues affecting providers and patients today. One of them is called EHR State of Mind, and you guys can look that up on your own. It's pretty fun. But if you badmouth the EMR in front of your patients, they pick up on that. They sense that frustration and that negativity, and that influences not only what they think of the EMR, but what they think about their care in general. It impacts their perceptions of the patient-doctor relationship and their overall satisfaction. So although you may have some frustration with the EMR, it's important that you keep that within yourself and don't express that to your patients. Instead, you should try and promote some of the value that the EMR brings, such as the ability to rapidly pull up their labs and review their last notes and their immediate access to their information and medical resources. Explain what you're doing as you're doing it. So of course there will be times in using the EMR where you have to attend to the computer. So instead of just shutting down and having silence between you and your patient, just talk out loud. We do this with our trainees all the time. Just say what you're doing. For example, well, I just need to put in that order right now. I'm going to put in an order. It's called a CBC. That's to check your blood counts and so on and so on. It keeps the conversational style of the interaction going, but it also clues your patients into what you're doing, and it may prompt further discussion, questions, clarification on their part. And last but not least, log off. So at the end of the visit, be cognizant and say, so I'm just going to log off right now so that your information is nice and secure and nobody that shouldn't have access to it won't have access to it, and log off. So I imagine many of you listening just now play a role in the education of trainees as well. So I want to point out some mandates that you should probably be aware of. One of these is by the Alliance for Clinical Education for medical students, saying that there should be a clear set of competencies related to EMR use, as well as the LCME, who accredits medical schools in the United States, saying that it's important that we teach effective communication both orally and writing, and that encompasses use of the EMR as well with patients, families, and our colleagues. And also with our residents, as I'm sure you're all aware of, these milestones also include communication skills, and some of them, depending on your different specialty, may actually specify use of the EMR in these communication skills and as it relates to documentation. So despite these mandates, very few attendings, much less medical students and residents, receive mandatory training on how to use the EMR in a patient-centered manner. So I'm just going to briefly tell you a little bit about what we do at the University of Chicago to try and incorporate some of that training in. So we start with our second-year medical students, and during their clinical skills doctoring course, we give them a 1-hour lecture on barriers and best practices of patient-centered EMR use. And then we let them practice by doing a group OSCE, an observed structured clinical examination with a standardized patient. So they actually get to use the EMR and have to use it in a patient-centered manner. We then give them a little booster prior to them transitioning to the third year, where we talk about technology skills, and much like that paper that Meg had alluded to about tech etiquette, we talk about your tech skills and general etiquette for its use on the wards. And then in the third year, we give them another OSCE, very similar, but just as another refresher, because longitudinal reinforcement of these skills through time is critically important. I won't go through our results in too much detail, just to say that our medical students all reported that it increased their knowledge, their confidence, and their self-perceived ability. And when we asked our standardized patient about their actual ability, our standardized patient agreed. Out of an 80-point scale that the SP would use, our second years scored 73.5 out of 80 points in terms of how well they were able to use the EMR in a patient-centered manner. And as a control, we had our third years do the same OSCE. The only difference was they didn't get that 1 hour of training, and they actually scored worse despite them having 1 full year of additional experience. So most of our second years scored excellent and good versus our third years, who actually scored quite a fair bit in the average, fair, and poor category. Our curriculum is on the AMC MedEd portal and is freely available for anybody to use. And if you have any questions, you can let us know. We further provide some curriculum for our residents in terms of lectures. We've tried to integrate it into our onboarding process. We provide training for our faculty as well, and our residents all respond that the training is effective, that it should be required, and that it would change their future practice. And similarly, our faculty agree as well, that it made them more aware of barriers and best practices, but more importantly, they felt more able to implement those best practices and teach our trainees. So it might not be the best way to teach it, but at least it's a way to try and integrate it into some of the curriculum, not just for ourselves, but for our trainees.
Thank you so much. That was really interesting. Just a little bit about .com. You can find out more about integrating the computer in the exam room on our Module 14. We actually have 42 modules altogether. And I wanted to let you know that all of you will receive, if you'd like, a free 30-day trial subscription to .com. You go to .com.org, subscriptions, webinar, SEP 16, and you will get a free 30-day trial subscription. Our next webinar, Unleashing the Positive Power of Compassion, Science, Skills, and Strategies for Health and Well-Being, will be given by Beth Lown from the Schwartz Center for Compassionate Healthcare on November 17th. And to register, just go to .com.org, resources, and then click on webinars. And our time is up, unfortunately, but thank you, our panelists, for that great information, and thank you to everyone who has attended. Thank you very much.